Ritika, my video is not coming.
Sir, I can see your screen.
Yep. All right. So a very good evening, everyone. So as a part of the continuation of the emergency medicine series, today we will be discussing the gastrointestinal emergencies. So in the gastrointestinal emergencies, so before going ahead with the session, I'm myself Dr. Rajesh Gubba. I'm the general medicine educator. So in the previous sessions, like we have discussed the neurology emergencies, cardiology emergencies, the pulmonology emergencies, endocrine emergencies, and then we have discussed even electrolyte emergencies as well. So in this session, I'll be discussing the gastrointestinal emergencies. Now, so if you take up the important gastrointestinal emergencies, what are those important gastrointestinal emergencies are? One, the patient will present to the emergency department with a gastrointestinal bleeding. So this gastrointestinal bleeding, either it would be an upper gastrointestinal bleeding or lower gastrointestinal bleeding. And the other presentations to the emergency department will be in the form of abdominal pain or in the form of the vomiting and as well as diarrhea. So these are the emergency presentations related to the gastrointestinal issues. Now, if you take the gastrointestinal bleeding, okay, so I'll just ask you a quick question here. Any one of you, whoever is there online, please answer this. So how will you differentiate the upper gastrointestinal bleeding from the lower gastrointestinal bleeding? So yes, if anyone can answer, that would be better. Any one of you, please. Yes, so how will you differentiate? What is the cutoff point to tell whether it is upper or lower gastrointestinal bleeding? Just a minute. Okay, so now the differentiating anatomical structure between the upper and as well as the lower gastrointestinal bleed, right? Very good, Shivani. That is the ligament of the treats. Okay, so above the ligament of treats, any particular source of bleeding will be called as the upper gastrointestinal bleeding, and distal to the ligament of treats, any particular source of bleeding which we consider it as the lower gastrointestinal bleeding. Now, so first, let me try to take up the discussion of the upper gastrointestinal bleeding. So what are all the various sources of the upper gastrointestinal bleeding? So peptic ulcers disease, like it can present with upper gastrointestinal bleed, gastrointestinal erosions, esophagitis, esophageal varices, Mallory-Weiss tear, and as well as the vascular malformations. So these are all the conditions which will present with the upper gastrointestinal bleed. Right now, so but what will be the presentation and what is the most common among all these? See, the most common etiology among the one which I have shown you is the peptic ulcers disease. The peptic ulcer disease, it constitutes nearly around 20 to 50% cases of the upper gastrointestinal bleeding, right? And from the medicine point of view, what is very much interesting here is about the esophageal varices. And esophageal varices presenting with upper gastrointestinal bleed, this is just seen only in 5 to 20% cases of the upper gastrointestinal bleed. Okay, and what is the least common cause for the upper gastrointestinal bleed will be vascular malformations. So vascular malformations, they present only 5 to 7% cases of the upper gastrointestinal bleed. Now, what is very important here is the presentation of the upper gastrointestinal bleed. So what are the various ways of presentation? So one way of presentation is the hematemesis. That is the common presentation of the upper gastrointestinal bleed. And it is because of the hematemesis, the patient will present to the emergency department. And the other presentation of the upper gastrointestinal bleed will be in the form of melena. Okay, so after the hematemesis, the next most common presentation of the upper gastrointestinal bleed will be melena, where you have the brownish color or blood within the stool. And what is very important, these two will be the presentations. But whenever the patient presents to you to the casualty, what is the first important thing that you have to assess? This is very, very important point you need to know. That is, you should assess the volume status of the patient. Right? You should assess the volume status of the patient. Now, how to assess this volume status? I'll discuss that in detail. And what is the very important diagnostic strategy that you have to follow? That is endoscopy. Just 1 minute. Right. So you need to do the endoscopy. Okay, so endoscopy is the very, very important diagnostic procedure which has to be followed for the upper gastrointestinal bleed. Now, so I have just given you the etiologies causing the upper gastrointestinal bleed. Now, let me tell you, see, one important question that will be asked for you is, what are these vascular malformations that can present as the upper gastrointestinal bleed? See, all these we are very much aware of: the peptic ulcer disease, gastrointestinal erosion, esophagitis, esophageal varices, Mallory wheeze, and vascular malformations, right? But what are those vascular malformations? See, like, how will you make out the etiologies, or like, this is the etiology for upper gastrointestinal bleed? Like, for example, you take peptic ulcer disease. What will be the presentation? There will be history of dyspepsia, or the patient will give you the history of the NSAID use, or there is past history of peptic ulcer disease. That will be the presentation, the clinical feature of the peptic ulcer disease, the history of the peptic ulcer disease. Then, see, if you want to make out the esophageal varices as a cause for the upper gastrointestinal bleed, so what will be the features in the patient? There will be signs of the chronic liver disease. That is, the patient might be having ascites, the patient might be having the pedal edema, the patient might be having the presence of the spider nevi. So these are the features of the chronic liver disease. And if that particular patient is presenting with the hematemesis, then you have to suspect the portal hypertension causing the esophageal varices and rupture of the esophageal varices causing the upper gastrointestinal bleed, right? Now, so how will you suspect the Mallory wheeze tear? So, for example, if the patient gives you a history of acute bleeding preceded by heavy alcohol ingestion, or if the individual gives you the history of retching, then you have to suspect the Mallory wheeze tear. Now, what is very, very important is, what are those vascular malformations which can cause the upper gastrointestinal bleed? Yes, can anyone tell me what are those vascular malformations that can cause upper gastrointestinal bleed? Yes, let me see who can answer. What are the vascular malformations that can cause the upper gastrointestinal bleed? So there are three most important vascular malformations. What are those three most important vascular malformations is, one, we have angioectasis, which is nothing but angiodysplasias. So angiodysplasias. Okay, so this angiodysplasia, what exactly is this angiodysplasia? See, the angiodysplasias, they are nothing but aberrant submucosal vessels, right? They are aberrant submucosal vessels. And what will be the dimension of these angiodysplasias? They are around 1 to 10 mm in dimensions. And what are they? They are aberrant submucosal vessels, which is caused by chronic intermittent obstruction of the submucosal veins. So basically, it is the submucosal venous obstruction, right? Submucosal venous obstruction. That is what is responsible for the development of your angiodysplasias. And what will be the shape of these angiodysplasias? They are bright red, stellate shaped, right? They are bright red, stellate shaped appearance. And these angiodysplasias, they occur throughout the gastrointestinal tract, but most commonly they occur in the right colon. Right, most commonly they occur in the right colon. That is about your angiodysplasias, which can present in the form of upper gastrointestinal bleed. Next, the second important vascular malformation which can present with upper gastrointestinal bleed is the telangiectasias. What are these telangiectasias? These telangiectasias, you can see here, right? They are very small. Okay, they are very small. Cherry red lesions. They are very small, cherry red lesions. And what are they again? They are nothing but they are caused by dilatation of venules. Right, they are caused by dilatation of venules. Okay, and these telangiectasias, they can be part of the systemic conditions. Right, what are those systemic conditions? These systemic conditions include hereditary hemorrhagic telangiectasia. Right, hereditary hemorrhagic telangiectasia, or they can also appear as a part of the CREST syndrome. They also appear as a part of the CREST syndrome. So these are the telangiectasias which can present in the form of upper gastrointestinal bleed. Next, now, can anyone identify this particular lesion presenting with the upper gastrointestinal bleed? Any one of you, please? What is this particular third lesion, a vascular lesion, which can present in the form of the upper gastrointestinal bleed? Now, this is a very, very important lesion, and this we call it as Dieulafoy's lesion. Right, this we call it as the Dieulafoy lesion. What is Dieulafoy lesion? Dieulafoy lesion is nothing but it is an aberrant, large caliber submucosal artery. Okay, it's an aberrant, large caliber submucosal artery, most commonly in the proximal stomach, that causes recurrent intermittent bleeding. Okay, so you have to understand that your angiodysplasia is the venous system. It is a submucosal vein. And even your telangiectasia, that is also the dilatation of the vein, but it is only the Dieulafoy lesion, which is a large caliber submucosal artery. Okay, so among these three vascular malformation, which is an arterial origin, that is the Dieulafoy lesion. Okay, so these are the causes for the upper gastrointestinal bleed. But out of all these, which is the most common cause for upper gastrointestinal bleed? That is peptic ulcer disease. Which is the least common cause? The least common cause will be the vascular malformations. Now, so quickly, you need to know like how to diagnose this upper gastrointestinal bleed. So you have to do the upper GI endoscopy. Right? This upper GI endoscopy should be virtually done in all patients with upper gastrointestinal bleeding. And this should be done within 12 to 24 hours of arriving in the emergency department. Now, when will you do within 12 hours? In all the high-risk patients, you have to do upper GI endoscopy within 12 hours of arriving to the emergency department. Whereas, in a case of moderate to low-risk patients, right? In case of moderate to low-risk patients, you have to do upper GI endoscopy within 24 hours. Now, I will ask you two important quick questions. That is, before doing endoscopy, I will give erythromycin. Now, can anyone tell me what is the purpose of giving erythromycin? And how much of erythromycin you have to give? 250 milligrams of erythromycin. That should be given intravenously. Right, that should be given intravenously 30 minutes before the procedure. Now, who will tell me why should I give the intravenous erythromycin 30 minutes prior to the upper GI endoscopy? Right, this is a very important question. Very, very important question in your upcoming NEET PG exam or FMG exam. Yes, who will tell me why should I give erythromycin 30 minutes prior to the upper GI endoscopy? Right, that is because, yes, any one of you, please. Okay, so it is not because the erythromycin is having the antibiotic nature. Remember, erythromycin, it acts as a prokinetic agent. You know what this erythromycin can do is, erythromycin can promote the gastric emptying. Right, it will promote gastric emptying, and thereby it will improve the quality of, right, it will improve the quality of the endoscopic evaluation. Right, thereby it will improve the quality of endoscopic evaluation. That is the purpose of giving the erythromycin. It is not for killing the bacteria. Okay, next. Now, in any upper gastrointestinal bleeding, what you have to administer first, once the patient present to the emergency department is, depending upon the volume resuscitation or volume levels, you should give IV fluids. Then followed by that, you should administer the continuous intravenous proton pump inhibitor therapy. Right? You should administer continuous intravenous proton pump inhibitor therapy before doing endoscopy. Now, what is the purpose of giving this continuous intravenous proton pump inhibitor therapy is, this continuous intravenous proton pump inhibitor therapy will decrease the number of ulcers. Right? Will decrease the number of ulcers. That is the reason why before doing endoscopy, you have to give continuous intravenous proton pump inhibitor therapy, right? So it's a standard clinical practice in many of the institutions to administer either an intravenous proton pump inhibitor therapy or high dose oral proton pump inhibitor therapy should be given prior to endoscopy, okay, in cases of upper gastrointestinal bleed. Now, once the patient has presented to you into the emergency department with upper gastrointestinal bleed, what you have to do, you have to categorize the patients. Is this the patient who is high risk, or is this patient with moderate risk or with minor bleeding? Now, how will you differentiate high risk, moderate risk, and minor bleeding? See, accordingly, the treatment completely changes. See, now the patient, right, the patient whose systolic blood pressure is less than 100 millimeters of mercury, right, whose systolic blood pressure is less than 100 millimeters of mercury, heart rate more than 100 per minute, and age of the patient around 60 years, age of the patient around 60 years or more than 60 years. These individuals with upper gastrointestinal bleed, they are considered to be high-risk patients. They require immediate fluid resuscitation. Then, who are considered to be the moderate risk patients? Who are considered to be moderate risk patients? See, moderate risk patients are those where the systolic blood pressure is more than 100 millimeters of mercury, but heart rate of the individual is more than 100 per minute. And age of the individual is less than 60 years. They are considered to be the low-risk patients. They are considered to be the low-risk patients. Okay. Then, who are considered to be the minor? Just 1 minute. Okay, I'm sorry. Right. So now, who are considered to be the minor risk patients, right? So the minor bleeding patients is that where the individual is having normal systolic blood pressure, right? And heart rate of the individual is less than 100 per minute. They are considered to be the minor bleeding patients. Okay. Now, what you have to do for this high-risk bleeding patient? Now, you are the emergency medicine physician in the casualty. Now, you are having a high-risk patient in front of you because of the upper gastrointestinal bleed. So, what is that initial stabilization that you will be doing? Yes. Who will tell me? What is that initial stabilization? So, in patients with significant bleeding, immediately connect the patient to 18-gauge needle. Right? And you have to connect to 18-gauge needle or a large intravenous line should be started prior to further diagnostic testing. After connecting to two 18-gauge needles, then immediately you have to start the IV fluids. That is 0.9% saline, or you should give ringer lactate or cross-matched packed RBC you should give. So 2 to 4 units of cross-matched packed RBC should be given, right? And it is very much preferable to place a central venous line and central venous pressure monitoring should be done. But again, please remember, central venous pressure monitoring is desirable in some cases, but line placement should not interfere with rapid volume resuscitation. Okay, so the initial stabilization should be done with the IV fluids. Now, coming to the blood transfusion, right? So what I am very much worried about is about this high-risk patient. If I don't handle the patient immediately, I'll be seeing the death of the patient in front of me by the cardiovascular collapse. Okay, so high-risk patient is very, very important for me rather than moderate or the minor bleeding patient, right? So after this IV fluids, the next important thing is the blood transfusion. So you have to give the packed RBC. Right, you have to give packed RBC. So this packed RBC should be given to maintain the hemoglobin, right? So how much of the hemoglobin you have to maintain? You have to maintain a hemoglobin of 7 to 9 grams per deciliter based on patient's hemodynamic status, comorbidities, and presence of continued bleeding, right? Now, whenever there is absence of continued bleeding, now, like how many units I should give? I should give 2 to 4 units of packed RBC. Now, what should be my target? 1 unit of packed RBC, right? 1 unit of packed RBC should rise approximately 1 gram per deciliter. 1 unit of packed RBC should raise the hemoglobin by 1 gram per deciliter. Okay, right? And one more important point I'll tell you. The transfusion of the blood should not be withheld from patients with massive active bleeding, regardless of hemoglobin value. See, the patient may tell you, or the patient attender may ask you, sir, you have done a complete blood picture in this patient and hemoglobin is like 11 gram per deciliter. Do you want to still give packed RBC? Yes. Transfusion of the blood should not be stopped in patients with massive active bleeding, whatever might be the hemoglobin value, okay? And what should be your target hemoglobin value whenever you are giving the blood transfusion? In those individuals where the hemoglobin levels have dropped, the target hemoglobin value should be more than or equal to 7 grams per deciliter. Okay, should be more than or equal to 7 grams per deciliter. So that is about your, so first I taught you about the IV fluids. Second, I have taught you about the importance of the blood transfusion. The next very, very important point is regarding the platelet transfusion. Okay, now, so if the patient is like actively bleeding patient, right? If the patient is actively bleeding patient, right? Then the platelets are transfused if the platelet count is less than 50. Yeah, Varun Kashyap. Yes, even though your blood pressure is more than 100 millimeters of mercury, you have to give IV fluids. Okay? Right? And that is a first line treatment in patients with high risk individuals. Okay? Right. Now, when will you give the platelet transfusion is the patient is actively bleeding and platelet count is less than 50,000 per cubic millimeter. These patients, you have to give the platelet transfusion, right? Or the other scenario where you have to give platelet transfusion is considered if there is impaired platelet function, right? If there is impaired platelet function due to the aspirin or clopidogrel use, right? Due to aspirin or clopidogrel use. So because of this aspirin or clopidogrel use, the patient is having impairment of the platelet function and actively bleeding, you should give platelet transfusion, right? You should give platelet transfusion. Now, the other scenario where there is dysfunctional platelets is in patients who are suffering with uremia. See, in uremic patients, even in uremic patients also, there is dysfunction of the platelets, right? There is dysfunction of the platelets. Then what will you give here? This will be the multiple choice question. Okay, patient is actively bleeding and the active bleeding patient is having dysfunction of the platelets, and the dysfunction of the platelets is due to uremia. What is the drug of choice is the question. Yes, any one of you who will tell me what will be the drug of choice? Yes, anyone? Right. So this will be the very, very important multiple choice question. Please remember this point. In this patient, you should give 3 doses of desmopressin. Right? You should give 3 doses of desmopressin, not fresh frozen plasma, Varun. You should give 3 doses of the desmopressin. Now, you may ask me, sir, how does desmopressin help here? Let me tell you, desmopressin, by acting on V2 receptors which are present at the level of vascular endothelial cells, these V2 receptors which are present on vascular endothelial cells will release the coagulation factors, right? They will release factor von Willebrand factor. This desmopressin also will release factor 8, and that can prevent the bleeding. That can prevent the bleeding, and this is a very, very important multiple choice question, right? Patient with active upper GI bleed, the patient is having dysfunctional platelets secondary to uremia. The drug of choice will be 3 doses of desmopressin, right? And what should be the dose of it? You should give this through intravenous route. The dosage is around 0.3 micrograms per kg you should give. Right? So this is about like the story related to the platelet transfusion, right? Now, I will give you some other scenario with upper gastrointestinal bleed, right? The other scenario is patient is having upper gastrointestinal bleed due to any of these etiology, but that particular patient is on anticoagulation therapy. That patient is on anticoagulation therapy. Will you do endoscopy or not is my question first. Endoscopy करना या नहीं करना? Will you do endoscopy or not? Is my first important question. Yes, right. So you are the emergency medicine physician, right? And you have referred the patient to the gastroenterologist to do an endoscopy, right? Now you are asking the question to the gastroenterologist, like, sir, patient is on anticoagulation therapy. Will you do endoscopy or not? What should be your answer? Right. So what should be your answer is, agar INR of the patient is less than 2.5, you can do endoscopy, right? If the INR of the patient is international normalized ratio of the patient is less than 2.5, endoscopy may be performed safely, no problem, right? But if the patient is taking warfarin, if the patient is taking warfarin and INR is more than 2.5, at this point, don't do endoscopy. What you should do at this point? In this patient, you should give either fresh frozen plasma or you should give prothrombin complex, right? 4-factor prothrombin complex. Now, one more question here. Between these two, between fresh frozen plasma and prothrombin complex, which is more preferred? This is another important question, because in your options, he will give you now. Patient's INR is like more than 2.5. Patient is on warfarin therapy, right? What should be the first line management? You can do endoscopy, first option. Second option, give fresh frozen plasma. Third option, 4-factor prothrombin concentrate. Fourth option, don't do anything, send the patient to home. What will you do now? Okay, so please remember, this is a very, very important point again. You have to prefer, very good Varun Kashyap, you have to give 4-factor prothrombin concentrate. Now the question is why? Why? Because this 4-factor prothrombin concentrate, it is more rapid in onset of action and it is effective at correcting the INR. Okay, so there will be rapid onset of action with 4-factor prothrombin complex in correcting the INR. So that is the reason why 4-factor prothrombin complex is preferred, not your fresh frozen plasma. Okay? So that is about the story related to a patient with gastrointestinal bleed, with oral anticoagulation, INR to less than 2.5, go ahead with endoscopy. INR more than 2.5, give fresh frozen plasma or 4-factor prothrombin concentrate. Reduce the INR to less than 2.5, then you go ahead with the endoscopy. That is about the story related to warfarin therapy. But you take this oral anticoagulants. These oral anticoagulants, apart from warfarin, we have some other oral anticoagulants also, like direct thrombin inhibitor is there. What is the direct thrombin inhibitor? This direct thrombin inhibitor is dabigatran. Dabigatran is a direct thrombin inhibitor. दूसरा oral anticoagulant is factor 10A inhibitors. Factor 10A inhibitor क्या है? Like they include rivaroxaban, right? They include rivaroxaban, or the patient is on apixaban, right? Or the patient is on endoxaban, right? Now, what will you do now? Okay, now what will you do? Okay, patient with upper gastrointestinal bleed, patient is receiving anticoagulation therapy, but not warfarin. Patient is taking dabigatran, or the patient is taking factor 10A inhibitor. Then, how will you restore the normal anticoagulation? So, you should know what is the antidote for dabigatran. What is the antidote for these three drugs? Yes. Now tell me, this is another important multiple choice question. What is the antidote for dabigatran? No. Varun Kashyap, don't continue with endoscopy here. You have to restore the normal anticoagulation within 24 to 48 hours. So you have to give the antidote first. What is that antidote? For your dabigatran, you have to give an intravenous monoclonal antibody. What is that intravenous monoclonal antibody? No. See, for dabigatran, the intravenous monoclonal antibody is ida. Okay, so ida ruxizumab. Okay, this is the antidote. This is a very, very important multiple choice question, right? The antidote for dabigatran, that is idarucizumab. Whereas, what is the antidote for these three drugs is what you are telling is correct. For rivaroxaban, apixaban, and as well as endoxaban, for that, you will be giving the reversal by andaxanate, right? That is andaxanate alpha. Okay, so this is a very, very important slide for your multiple choice question. Dabigatran antidote, idarucizumab. Rivaroxaban, apixaban antidote, andaxanate alpha. Okay, right. So that is about like what you have to give before doing endoscopy. Now, the other important thing is, okay, these are the things depending upon the different clinical scenarios. Now, coming to the upper gastrointestinal bleed. So what is that acute pharmacological therapy that you have to give is either you give the intravenous proton pump inhibitor therapy, or you should give oral proton pump inhibitor therapy. Now, which patients require intravenous proton pump inhibitor therapy? Those patients who are having high risk. What is that high risk feature? High risk feature include systolic blood pressure less than 100. Heart rate more than 100 per minute, then age more than 60 years. Those patients, they require intravenous proton pump inhibitor therapy. So that intravenous proton pump inhibitor therapy, either you give esomeprazole or you should give pantoprazole. Okay, how much you should give? You should give 80 milligrams bolus. Then followed by that, you should give infusion. How much should be that infusion followed by the bolus? That is 8 milligram per hour should be given. For how long you should give? You have to give this for nearly around 72 hours. That is for high risk patients, you have to give IV. Okay. Then you take for low risk patients. For low risk patients, you should give oral proton pump inhibitor therapy. That oral proton pump inhibitor therapy, either you can give the omeprazole, right? Or you can give esomeprazole, or you can give the pantoprazole. Okay, so any of these drugs, the dosage is same, 40 milligrams. Omeprazole, esomeprazole, pantoprazole, the dosage is same, 40 milligrams. But when you are giving this lansoprazole, the dosage is 30 to 60 milligrams. 30 to 60 milligrams. So you should give this oral proton pump inhibitor therapy once or twice daily, right? Once or twice daily. Okay. So this is about the story for like acute pharmacological therapy. And one more important, one is your TK, one your proton pump inhibitor therapy that will prevent the development of further ulceration. Then the other important drugs is the octreotide and terlipressin. These drugs are very much useful in case of, right? These drugs are very much useful in case of the esophageal varices. Right, esophageal varices. Okay, so this intravenous octreotide, like what should be the dosage of this continuous intravenous infusion of the octreotide? You should give 100 micrograms bolus. After this 100 micrograms bolus, this is followed by 50 to 100 micrograms per hour should be given. Now, what is the mechanism of action of the octreotide? Octreotide will reduce the splanchnic blood flow. Octreotide will reduce the portal blood pressure. So in that way, it will control the initial bleeding. So what this will do? This will control the initial bleeding by reducing the splanchnic blood flow and by reducing the portal blood pressure. Okay, right. And coming to your terlipressin. See, in countries where it is available, terlipressin may be preferred to the octreotide. Right, terlipressin may be preferred to the octreotide. Right, what is the reference? I'm giving you the reference. This reference is from CMDT 2022. Right, CMDT 2022 is a reference. Okay, right. So terlipressin may be preferred to the octreotide in the countries where terlipressin is available. Now the question is why? In what way the terlipressin is more advantageous compared to that of your octreotide? See, terlipressin, because it is more advantageous because of its sustained reduction of portal and variceal pressure. Okay, sustained reduction of the portal and as well as the variceal pressure, and it will also reduce the mortality. Right, it is also the one which will reduce the mortality. So that is about, so in acute pharmacological therapy, like what is that you have to do? Like one is your proton pump inhibitor therapy, and second one is acute pharmacological therapy. Now, once the individual is stabilized, right? Once the individual is stabilized, you have to do an endoscopy now. You have to do an endoscopy now. So you have to do endoscopy within 12 hours for high-risk patients. You can do endoscopy up to 24 hours in moderate to low-risk patients. What is moderate risk? What is low risk? Already I have taught you. Now, coming to endoscopy. Once you have done an endoscopy, you have seen that there is actively bleeding lesion. When there is an actively bleeding lesion, you have to achieve the hemostasis. So how will you achieve this hemostasis? You have to achieve the hemostasis with endoscopic modalities, like you have to do cautery, right? Or you have to give the injection of epinephrine, or you need to place the endoclips. You need to place the endoclips. Okay, so that is for bleeding lesion. And those where you have done an endoscopy but there is non-bleeding varices, in those cases you can do the application of the esophageal variceal ligation, right? Esophageal variceal ligation. Okay, right. So this is, and not only that, you can also do the injection of the epinephrine, right? You can also do the injection of the epinephrine. So this is for the endoscopic therapy. Now, you have done an endoscopic therapy, right? But endoscopic therapy did not work. Endoscopic therapy failed. Then what is the next option, right? Then what is the next option? See, the next option is the intra-arterial embolization or the TIPS, that is transesophageal intrapulmonary systemic shunt, right? Transvenous, it is not transesophageal, I'm very sorry. Transvenous intrahepatic portosystemic shunt. Now, you take this angiographic treatment. We call it as angiographic treatment. Angiographic treatment is used in patients with persistent bleeding from ulcers, angiomas, or Mallory-Weiss tears who have failed endoscopic therapy, right? Who have failed endoscopic therapy. Okay, so failed endoscopic therapy. Okay, we can do this intra-arterial embolization. Right, the other one is TIPS. So what is this TIPS? Transvenous intrahepatic portosystemic shunt, where you will place a stent, from hepatic vein, right, from the hepatic vein to the portal vein, right, to the portal vein, okay, through the liver. Now, what is the advantage of keeping a stent between the hepatic vein and portal vein? This will effectively decompress the portal venous system. Okay, so this will cause the decompression of the portal venous system and control of the acute variceal bleeding. Okay, so it is indicated in patients in whom endoscopic modalities have failed to control the acute variceal bleeding. Right, then apart from this, these are permanent methods, right? Your TIPS is a permanent method. It's a final treatment option. But before going to that particular story of TIPS, what are the temporizing measures? What are the temporary methods? The temporary methods are the balloon tube tamponade, that is Sengstaken Blackmore tubes. So in patients with, massive variceal GI bleed, yes, Tej Kumar, hi. Right, in patients with massive variceal gastrointestinal bleed, mechanical tamponade with specially designed nasogastric tubes containing large gastric and esophageal balloons, your Sengstaken Blackmore tube, or this we also call it as Minnesota tube. Right, so these are the esophageal balloons. So these will provide the initial control, right? These will provide the initial control in almost 60 to 90% of patients. Okay, 60 to 90% of patients. Okay, so this is about the temporary methods. Now, once you have controlled by using the temporary methods, then you can do the either intra-arterial embolization or you can do the TIPS, that is transvenous intrahepatic portosystemic shunt. Right, now the next important is, after you have done these TIPS and all the final measures, like what is that you will do to prevent the rebleeding? Okay, so to prevent the rebleeding, what you can do is you can give the beta blockers. Right, you can give beta blockers. Okay, so what is that beta blockers which are preferable is the propranolol, right, and the other drug like what we have is the nadolol. Okay, propranolol and nadolol. So they will reduce the risk of rebleeding from esophageal varices by up to 40%. It will reduce the rebleeding by up to 40%. Okay, so and along with these beta blockers, what you can do is you should do esophageal variceal ligation. That will prevent the further bleeding. Then the next important point is, in patients with cirrhosis of liver with portal hypertension, when will you do liver transplantation? Okay, when will you do liver transplantation? See, orthotic liver transplantation should be assessed in all patients with chronic liver disease and bleeding due to portal hypertension. Right? Transplant candidates should be treated with band ligation or TIPS to control bleeding the pre-transplant. Okay, so you have done TIPS, right, or you have done esophageal variceal ligation, then you go ahead with the liver transplantation, that too when in advanced cases of liver cirrhosis. Right, in advanced cases of liver cirrhosis. So this is about the management of the upper gastrointestinal bleeding. So let me just summarize whatever I have taught you. So the gastrointestinal emergencies are mainly gastrointestinal bleeding, abdominal pain, vomiting, and diarrhea. But what I am taking into the discussion here is today the gastrointestinal bleeding. And again, we have two types, upper and as well as lower. What is the anatomical point of difference? That is ligament of Treves. Above the ligament of Treves, upper gastrointestinal bleed. Below the ligament of Treves, lower gastrointestinal bleed. And what are the various causes? The most common cause will be peptic ulcer disease, and the least common cause will be the vascular malformation. And the presentation will be in the form of hematemesis, melena. And you have to check the volume status, right? And the next important is you should know the vascular lesions. What are those vascular lesions which can present as the upper gastrointestinal bleed? Is angiodysplasias, telangiectasias, then gulifoil lesion. Then immediately what you have to do is you should do the initial stabilization. And after that, within 12 to 24 hours, you need to do the upper GI endoscopy. And 30 minutes before doing upper GI endoscopy, you should give erythromycin. That is mainly to promote the gastric emptying and may improve the quality of endoscopic evaluation. Then you should also administer the intravenous proton pump inhibitor therapy to decrease the number of ulcers. Then you have to categorize the patient to high risk, moderate risk, and minor bleeding. High risk patient, systolic blood pressure less than 100, heart rate more than 100 beats per minute, age of the patient more than 60 years, high risk patient, right? Systolic blood pressure more than 100, but heart rate more than 100 beats per minute, moderate risk patient. Blood pressure normal, heart rate is also normal, minor bleeding. Now, what is that I'm very much worried about is a high risk patient. So initial stabilization should be done with the IV fluids, either normal saline or ringer lactate or the blood transfusion. And whenever I am giving blood transfusion, my target hemoglobin should be more than 7. And even though hemoglobin is normal, but there is massive upper GI bleed, I will be giving the blood transfusion. When will I give platelets? When the platelet count is less than 50 and the patient is actively bleeding, I will give platelet transfusion. Or the patient is having platelet dysfunction because of aspirin or clopidogrel therapy, then also I will give platelet transfusion. Right? And in those individuals, due to uremia, if there is dysfunctional platelets, in them, I will be giving desmopressin. Then when the patient is on anticoagulant therapy, if the INR is less than 2.5, go ahead with endoscopy. But when INR is more than 2.5, then you should give either fresh frozen plasma or 4-factor prothrombin complex concentrate. But which is more preferable? Prothrombin complex concentrate is more preferable. And when the patient is on direct thrombin inhibitor like dabigatran, you should give an antidote, that is idarucizumab. But when the patient is on the factor 10A inhibitors like rivaroxaban, apixaban, and endoxaban, in them you need to give the antidote, that is andexanate alpha. Right? Then what is the acute pharmacological therapy? IV proton pump inhibitor therapy should be given, that is esomeprazole or pantoprazole, 80 milligrams bolus, and then followed by that 80 milligram per hour should be given. Then the IV octreotide or terlipressin should be given because they will reduce the splanchnic blood flow and reduces the portal venous pressure. Then in endoscopic therapy, if there is active bleeding lesion, you have to do cautery or you have to give injection of epinephrine or endoclips. Right? And in those individuals where the endoscopy has been failed, then in them, you need to do the intraarterial embolization or TIPS, that is transvenous intrahepatic portosystemic shunt. And temporary therapy should be the balloon tube tamponade, that is your esophageal balloons, that is Minnesota or Sengs taken Blackmore tube has to be placed. Right? And after that, you can do the TIPS. And how will you prevent the rebleeding? That is by giving non-selective beta blockers, that is propranolol or nadolol should be given. Along with this non-selective beta blockers, you should also do esophageal variceal ligation. And whenever there is diffuse liver involvement or end-stage liver disease, in them, liver transplantation should be done. But before doing liver transplantation, you should do TIPS or the band ligation to control the bleeding. Okay, so this is about the important emergency, that is upper gastrointestinal bleed, how you will manage. So with this, I'll wind up this particular session, right? And if you want to have the PDF of this session, you can join my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, right? Where I'll be posting this particular PDF to you, wherein you can download the PDF and you can use for your upcoming exams. Thank you very much. See you in the upcoming sessions. Yes, Harshita Pandey, hi.